Then I'll present two cases where we use chimney grafts in the carotid and innominate arteries. Here the arteries per se are not diseased. We use them for treating aneurysms, and using chimney grafts expands the range of aneurysms you can treat. And this was in the last couple of years, and at this time we didn't have fenestrated grafts. So here's a 70-year-old male who came with this large aneurysm of the aortic arch involving the left subclavian artery, and he had come with chest pain, and oh, I don't see this running. Is there any way to make this run? I'm sorry, this is not running, but anyhow, I'll take it that there was a large aneurysm, and we wanted to treat it. So we decided to use a chimney graft. So we came in through the left common carotid artery with a micropuncture needle and put in a sheath and deployed the aortic graft, and simultaneously had the chimney graft being placed there. Prior to that, we had coil embolized the left subclavian artery, and I hope we can, yes, okay. So, oh no, this is not, this is, actually there's some kind of mix-up. This is actually the second case. I don't know how this has come up. Anyhow, there's a mix-up in the angiogram, but this was the follow-up that we got. We can see that the aneurysm was excluded, and the left carotid artery was preserved with the use of that chimney graft. Yeah, this is the follow-up reconstruction CT on the right side, X-ray on the left, and you can see the patent left common carotid artery and the coiled off left subclavian artery and the excluded aneurysm. I'll quickly go on to the next case. This was a young patient with Takayasu arthritis who came with hoarseness of voice, and he had left arm claudication. He was in active phase of arthritis. He had a CRP of 69, and his X-ray showed a couple of bumps like this, which looked like aneurysms. And this was his angiogram. He had a huge arch aneurysm and another aneurysm of the descending aorta with a normal-looking segment in between. And we decided to treat this with stent grafts, but you can see the landing zone would occlude both the innominate and the left common carotid artery. And so we would have to use something to preserve those two. And you can also see that the left subclavian artery was occluded and was being fed through a collateral from the left carotid. So we first got a left carotid, left subclavian bypass done so that we got flow down the left subclavian artery. And this was the post-operative angiogram. And then we decided to do the endograft procedure. But when we tried to get the graft into the arch, it kept going up into this aneurysm because there's no support from the arch to take this delivery system into the ascending aorta. So we had to improvise a transseptal system of pulling this delivery system into the ascending aorta. And this looks a bit complicated, but basically in the two labels marked in yellow, the one label marked in yellow is a transseptal sheath, and that's being held in place by a wire that's been snared and held in the descending aorta. That's marked in blue. And then through this sheath, we brought another snare and got hold of the delivery system wire of the aortic stent graft and then pulled it down. And I hope this runs. Yeah, this shows how we actually pulled that aortic stent graft delivery system down into the ascending aorta. And you can see the two chimney grafts ready to go in the innominate and left carotid artery. And then keeping the traction on, we delivered the aortic stent graft. So we had a very stable position. We didn't have to go into asystole or anything like that. And we deployed the aortic stent graft. Prior to that, we deployed another one in the descending aorta. And then we deployed the two chimney grafts. And this was the final kissing balloon dilatation of the chimney grafts in the aorta. And think, yeah, this is the final angiogram, which by mistake came in the previous case also. But you can see the innominate and left carotid chimneys flowing very well, the aortic aneurysm excluded, and the lower aneurysm was also excluded. So we got exclusion of both the aneurysms with preservation of the arch vessels. And this is the follow-up CT scan showing thrombosed aneurysm sac, the chimney grafts patent. You can see the chimney grafts and the aortic graft competing for space in the ascending aorta. And he's doing well at follow-up. He's now more than a year now. So we can use chimney grafts to preserve aortic arch branches when we do endovascular treatment of aortic arch aneurysms. And in that second case, we had a system by which you can actually pull these grafts down into the ascending aorta if it's difficult to deliver them there. Thank you.
Thank you, Dr. George. It's an excellent case, presentation, and congratulations to you. The question I'm going to ask you is that, did you try to find out any infective cause for these aneurysms?
Yes. Actually, that second patient had features of Takayasu arthritis, the occluded left subclavian artery, the elevated inflammatory markers, and that has persisted over time. So now we've got him on immunosuppressive therapy, and we are actually treating him long-term with immunosuppression therapy. But in the earlier days, we used to look actively for tuberculosis in these patients, but found that actually there is no association between tuberculosis and Takayasu arthritis. So we now don't bother about treating them with anti-tuberculous therapy. But at one time, say about 15 years back, routinely all of them got ATT.
And I see that you have occluded the left subclavian artery.
In the first case, not in the second.
Also in the first case.
Yeah.
Was there any spinal problem?
No, there wasn't. Actually, that case, those days we used to kind of occlude subclavians with impunity, but now we are very much more careful about that.
Yeah, George, can I ask you
Chairman, we'll move on to the next presentation because we have to catch up with the live coming up. Professor George Joseph would continue, and that comes in the form of case number 13, total arc revascularization in NSW.